Yeah, I think in 2025 we'll build on what's changed recently in the last 1 to 2 years with the management of upper tract urothelial carcinoma, with the OLYMPUS trial, and then the WALDU data, the real world evidence. We see that JELMYTO is being used as a chemoablative as well as an adjuvant agent in patients with upper tract urothelial carcinoma. So I think that adoption will continue, and I think as urologists, we need to really risk stratify these patients, identifying low-risk patients that have low-grade disease based on biopsy, have low-grade cytology, and have tumors less than 2 centimeters. We should adopt a kidney-sparing approach, an endoscopic approach with the use of JELMYTO to spare these patients the morbidity of a radical nephroureterectomy. With the key takeaways this year with UTUC are, that JELMYTO can be used in the office. We're seeing a lot of antegrade nephrostomy tube use for application of this. We're seeing increased use of maintenance therapy. At the AUA last year, there was some very good data. It was a small series, but that maintenance does have a benefit in patients that do respond to JELMYTO. We're seeing a lot of that. I think robotic surgery is here, and it's going to continue to evolve. We're seeing applications with single port radical robotic nephroureterectomies. I think that will be continue to grow. I think that the use of a lymphadenectomy, it's within the guidelines, it's recommended. I think that we need to use that more often in everyday practice. I think, again, going back to who's the appropriate candidates, who needs surgery, who can be managed endoscopically, I think that's where we have to focus on. I think that, unfortunately, UTUC is a small disease state. There's not a tremendous amount of patients that suffer from this disease, but when you extrapolate what's going on in bladder, especially advanced bladder cancer, we're seeing significant innovation, significant application of immunotherapy. We can look the Niagara trial, which just was released at ESMO recently. If you extrapolate, that was in bladder cancer, but if you extrapolate that to upper tract urothelial carcinoma, you can make an argument. So, I think we there's no significant studies to have supported it, but I think, again, in bladder cancer, and usually we extrapolate bladder cancer to upper tract, we're going to see more and more immunotherapies being applied. I think as a urologist, what I'm looking for is to see more data on maintenance therapy and the management of our tract urothelial carcinoma with JELMYTO. I think, is there any biologic markers to predict responders? I think there's a lot of opportunity for tumor sequencing, identifying who will respond to what therapy. I think there's a lot of opportunity there to help better manage these patients.